I would like to thank Daryl for the kind opportunity to speak here and give you some updates in the world of prostate cancer. My disclosure, as you heard from Dr. Cheetham, is that I am a genitourinary medical oncologist. I do not alter body parts. I do not pickle the prostate. I do not do anything with your peckers. My job is to try to keep everything intact and functional for you. I'm charged today with something very different, and that is to talk about a different part of treatment of your prostate cancer. The great thing I can tell you right now is that people are living longer with prostate cancer. People were making reference to the fact earlier that when we're talking about getting a cancer, I mean, how much worse can that be? The best thing I can tell you, if you're going to have cancer, have prostate cancer now. Why? We probably have more treatments available for your oncologic lifetime, that is, during all the treatments that you're going to need, than you could possibly utilize. Very few cancers have that kind of treatment history. So remember, there's a spectrum in prostate cancer. The spectrum is we have our localized disease that our urologic colleagues spoke about. We have disease that starts to return in that miserable form of what we call a biochemical relapse, or the only manifestation that your disease has come back after primary surgery or radiation or both, which is your PSA. Now, everybody knows what PSA stands for, right? No, you don't. Everybody thinks it stands for prostate-specific antigen, promotes stress and anxiety. And usually it isn't a headache for me because, or Dr. Autio, because we both treat prostate cancer, because everybody focuses on the darn number. I don't. I really don't care. There are ways we look at the numbers, we look at doubling time, et cetera. But all PSAs aside, as I would like to say, we do, excuse me, get to a point in the oncologic transition as somebody goes from localized disease to rising PSAs to perhaps a point where we have to initiate treatment with hormonal therapy in the setting of something that either pops up on a scan or people have been on hormones after their surgery or radiation for the rising PSA, and they suddenly decide that, well, I guess I have to stay on hormones for the rest of my life, but then are very concerned when their PSAs start to rise. Now, what does that mean? Well, you can have disease that pops up for which hormonal therapy is appropriate. And what are we doing with hormonal therapy? We essentially are using drugs to knock down the male hormone testosterone such that we starve the cancer. And many of you have heard the term castrate resistant. Well, under the influence of hormonal therapy, we strive to bring the testosterone that can be measured in your blood to a value of less than 50 nanograms per deciliter. I only make the mention of the word number 50 because sometimes that's what we use in clinical trials, but the point is we are putting you through a chemical-induced menopause. I prefer not to say castration, and having been through menopause, I'm very empathetic with my patients, so when they talk about their hot flushes and everything, I sort of nod my head and say, well, now you know. So the point is, as commiseratory as I am, many of the wives will sit there and nod their heads and say to the husband, so now you know as well. So we're all there discussing our hot flushes together. Now, in the course of your treatment, and when your testosterone goes down, it's very obvious you may or may not have side effects. And those side effects can be hot flushes, the side effects can be mood swings. Certainly about 5% of men will often come in saying that they have what we call psychic orgasms, that they are not able to have intercourse, but with some manipulation they find they're able to have an orgasm, albeit a dry ejaculate, but otherwise are perfectly content. Again, 5%. But then you have other people who, especially my older patients, 80 and above, who start reading the side effect profiles, and right after starting hormonal therapy, the next day will say to me that they have every one of the side effects. Their testosterone hasn't even come down yet, but they've already developed the hot flushes just by looking at the side effect profile. We all find that as we transition from localized to rising PSAs to being on hormonal therapy, there will be a time that the cancer will change. And we will start to see it radiographically, meaning we will see it on a bone scan or a CAT scan or other imaging modalities such as PET scans. And while that is the case, I would be the first one to tell you that does not mean you're going to die. It does not mean that you will not respond to other treatments. We have so many treatments now. I actually had 3 patients in my office last week, one of whom had prostate cancer for 30 years, and the other 2 are approaching 22 and 23 years respectively. Now you're probably all saying, oh, they probably localized disease. No, they were Gleason 9, high grade, and they were told by their doctors many years ago that they wouldn't be around 5 years later. And we've all been dating for over 20 years together. So the reality is you can live longer, and there's a lot of things to do. Now, that being said, there will come a point that in spite of being on hormonal therapy, let's say you're on hormones after surgery or radiation, that your disease will either be seen on a bone scan or a CAT scan, or all of a sudden the hormones are no longer working. Now, how do we know? Well, we know that we have to maintain a very low level of your testosterone, what we call castrate levels. We discussed that. But we start to see the PSA rise. So a PSA optimally should go less than 0.05. It should go to 0 on hormonal therapy. When the PSA starts to rise while you're under the influence of that medication, that means that you have resistant disease. We often term it castration resistant. Why? Because your testosterone is less than 50. It's stayed down, but your PSA is no longer controlled. And as the PSA goes up, or doubles or triples, sometimes we see an accompanying change in a bone and CAT scan for which other medications, usually pills, and there's a whole group of them, can be added. What's unusual now, and where I'd like to focus for a few minutes, happens to be what we call the M0 state. So M1 means I see things on bone scan, little ditzels in bone or something in a lymph node, nothing that would get me excited. However, very often, we never have the opportunity to see what we call M0. So essentially, your PSA is rising despite low levels of testosterone. It may go to 2, it may go to 4, it may go to 400, but we do a bone scan and a CAT scan, and we don't see anything. Now, I'll be the first one to tell you I rarely see that. It's about catching people. So sometimes you can be under the influence of hormones, your PSA is going up, there's nothing, but your next scan, depending on how aggressive your doctor is, may not be for 3 months, it may not be for 6 months, it might be a year later. And all of a sudden you come back with disease. So it's not every patient that we can catch when their scan is still without having progressed. So the M0 state came into evolution largely because it represents an unmet need. It's a group of men who have rising PSAs, and the question is, there's nothing on the scan, so what should we do? We have options. We have docetaxel, we have cabazitaxel, we have a drug called sipuleucel T, which is the first immune therapy for a solid tumor, in particular prostate cancer. It's your own cells that have been changed and given back to you. I'll talk about that in a little bit later. But we have a lot of different treatments. And there have been at least 3 pivotal clinical trials that led to the approval of 3 drugs now that have been shown to what we call metastasis-free survival, or a benefit in treating those patients who just happen to capture at that M0 time before they become metastatic, that is associated with significant benefit. Now, I'm sure many of you have already heard about it. It's interesting because at least 2 of these drugs have been approved in different states or treatments for prostate cancer. Many of you know enzalutamide or Xtandi. That's been approved pre-chemo, post-chemo, et cetera. And in a study that was performed, enzalutamide, the name for Xtandi, as I just mentioned, is that it has shown a very significant survival benefit in this M0 patient population. Not to be outdone, there is a second-generation one called apalutamide, or Erleada, and that has also been shown to have what we call metastasis-free survival benefit, meaning you're going to do very, very well. Metastasis-free survival means the time that you start the drug, and you have no evidence of disease, until the time the drug no longer works is evidenced by the appearance of the first metastatic focus. So that's what we call metastasis-free survival, meaning how long are you living until we see that your cancer has changed its state and you need a different treatment. More recently, a third drug came out, which is called darolutamide. It's another relative. It sounds like the amides are all part of the family, and if you go back in time, their great-great-grandparents were bicalutamide and flutamide, which are the original anti-androgens that you may have heard of or been treated with years ago, called Casodex and flutamide. So there's a whole family of them. All three have now been FDA approved for the M0 state, meaning just a rising PSA in the setting of very low levels of testosterone and in the absence of any metastatic disease that you can see on imaging. Now, when we talk about really a sea of plenty, 3 drugs, all for the same thing, all showing improvement anywhere from threefold, so 14.6 months or 16.6 months to 42-point-something months. That's the benefit, and it translates into almost a survival benefit as well. And it's the first time that the FDA has ever approved drugs based on the endpoint that was not really overall survival or what we call progression-free survival, but metastasis-free survival. Remember, the time from going on the drug until you start to see the first metastatic focus on imaging. Now, the question I'm sure many of you have asked your doctor is, gee, doc, you have 3 of them. They all do the same thing, and they actually do, because they work by preventing any testosterone that's floating around in the body from binding to the tumor cell and making the tumor cell grow. Now, we already know you're on a hormone, right? It could be Eligard, it could be Lupron, it could be Zoladex, and therefore we know that your testosterone is all the way down. But what people don't know is that the cancer cells, when they become resistant to the standard treatment, start to make their own testosterone. I call it autoerotic stimulation of the cancer cell, largely because the cancer cell puts on its surface or expresses the androgen receptor. The androgen receptor then gets stimulated by the prostate cancer's own production of testosterone. So that testosterone binds to the site on the tumor cell, and everything starts to go, and it starts to make the cells divide. All of these drugs will bind to the androgen receptor and will not allow that complex to translocate or get inside the cell and ultimately into the nucleus, where the cell will then start to make transcription proteins and start to divide. So it's a very clever system, prostate cancer. You can't trust it, so you always have to keep on one step ahead. All 3 of these drugs, as I said, are FDA approved, and what's very important for everybody to know is that how do we, as physicians, make the decision of which one do you use from this sea of plenty? So there are side effects, and as you go down from enzalutamide, which was the first one, to apalutamide, the second one, to darolutamide, the third one. It's called Nubequa, I forgot to mention, Nubeqa, so that's the name of the third one. There is no question that the side effect profiles are very different. Again, it depends on the person and the side effects that the patient may experience or the patient's medical history. We do know that enzalutamide does cross the blood-brain barrier, has been associated with seizures, although there had been a paper that came out to suggest that the rate of seizures of patients taking this drug was no greater than the average population who was on hormonal therapy. However, we've noticed that older people seem to have an unsteadier gait, which is exacerbated by use of the drug, and there seemed to be a higher fracture rate. All 3 drugs cause fatigue, but again, what is fatigue? I mean, every one of my patients, they can be 80 and over, and they're out going out to dinner, they're going to the gym, they're on the golf course. I'm tired at the end of the day, and I'm running between rooms, but they have a very full day as well. Fatigue should be valued as what is changing your life. So if suddenly you have a nap or 2 or 3 during the day, that's fatigue. That is drug related, as opposed to coming home and saying, well, I did this all day, I'm tired. And very often, until you really dissect out what somebody's doing during the day, we're blaming the poor drugs, and then we end up changing the drugs because we think we're impeding your quality of life. So all 3 of these drugs cause fatigue. Enzalutamide will purportedly exacerbate patients' abilities to fall, meaning that if you're an older person, you may fall, you may be a little bit more unsteady on your feet. So if somebody's coming in who's older, I might say, this is not what I want to give you. Apalutamide, very well tolerated as well, much, much, much less passage into the brain, so it doesn't seem to make it through the blood-brain barrier as significantly as enzalutamide. And of interest is the fact that it can cause a rash, and it can cause some hypothyroidism. So if somebody who has a pre-existing hypothyroidism or has something dermatologic, I might not want to use that. Darolutamide is the least penetrant of the spinal canal, so it doesn't really cross, and it doesn't seem to have the same side effect profile. So again, every person coming in, it is really not what you want, although I know patients come in, oh, I read about this, and I want to try the newest drug. Please defer to your doctor's judgment on this, because we have to look at the whole person. We're not just looking at your cancer, we are looking at all your medical problems as well. I don't see my patients from the waist down, to be perfectly honest with you. And by the way, just as parenthetically, after Dr. Cheetham had said it, I also have a very small finger when I do rectals. So, and it is appreciated by a lot of my patients. So the one thing I will tell you is that, in general, these drugs do offer an opportunity, but it is not for every patient. Now, be aware that we don't catch every person who has M0 disease. Now that says something to the accelerated nature of the disease, that sometimes between the time that we've seen you last and the time of your next visit, your disease could have already progressed, and therefore other treatments would be needed. I can tell you that I don't see that many people who have M0 disease, again, and I frequently image people every 3 months, so it's really about the behavior and the biology of the cancer that really dictates how we evaluate you. The other very, very important thing to keep in mind is that we are not 100% certain that every patient who presents with M0 disease really has M0 disease. Many of you have heard about new imaging modalities, the PET scan, positron emission tomography, and there are different tracers that can be used. So we now have PSMA, prostate-specific membrane antigen. It's a molecule that's expressed on patients' cancer cells that have become resistant to therapy. That can be used hooked up to a radioactive compound and as an antibody or a small molecule, and brings with it a tracer so that you can see where there's hidden disease. There's something called an Axumin or flucyclovine scan. All of these work on different levels of detection, largely either through amino acid metabolism. There's something called a choline PET scan. They're not perfect. Sometimes we have a lot of false positives, so the presence of disease there that we think is disease until we biopsy it. But the point is, in the M0, with this new imaging, we have found that we are picking up people's disease that has been hidden or occult despite the use of bone scans and CAT scans. Therefore, does M0 really exist? Well, it depends on who you talk to. And not every doctor has the ability to hook into a bone scan or a CAT scan with these kinds of sophisticated other secondary studies. So this is something one needs to keep in mind. Immunotherapy. It's a very challenging area. I've been doing it for over 40 years. We've looked at vaccines. We've looked at a lot of things. But it's odd that prostate cancer, which is the first solid tumor in which an immune therapy was FDA approved, meaning Provenge, it showed a 3.5-month survival benefit, ended up with the fact that it doesn't really respond to a new group of immune therapies called checkpoint inhibitors. prostate cancer is what we often report as sort of a cold microenvironment, meaning there's not a lot of inflammatory cells in prostate cancer. And in a lot of the other solid tumors, such as melanoma, head and neck cancer, lung cancer, kidney cancer, bladder cancer, we know that there's a lot of mutations that occur. But in addition to those mutations, we know that they're very hot environments, meaning a lot of inflammatory cells. And these are the ones that seem to respond the best to this group of immune therapies called checkpoint inhibitors. The checkpoints are nothing more than our antibodies that lift off the brake that holds your immune system in check and prevents it from reacting to itself. It worked beautifully in melanoma, kidney cancer, lung cancer, bladder cancer, head and neck cancer, even some colon cancers, but only under very limited situations. What do I mean by limited? You need to have a genetic alteration. So it's been found that if you carry a mutation, a familial mutation, meaning it's been carried down in the generations, such as the BRCA or the breast cancer gene 1 or 2, or you have something called as microsatellite unstable, meaning a mutation that was often first seen in colon cancer, but it just says that there's something very unusual about the cancer in terms of the way it responds to therapy. These are the cancers that have alterations, or several of the alterations, that would allow you to respond. So very often, we've tried prostate cancer for years and have not found it to be terribly responsive to this group of therapies. There are data coming out to suggest that one of the drugs called pembrolizumab may be very useful in combination with enzalutamide, as well as the fact if you have some of these genetic alterations, you may have an opportunity to respond a lot better. We call this an agnostic approval, meaning that patients or solid tumors that carry mutations will respond to it. Unfortunately, immunotherapy has not been the greatest for prostate cancer, and everybody comes in and says, Opdivo, a chance to live longer, and patients come in and they want the drug. None of these drugs are lightweight. You know, everybody wants drugs. The immune checkpoint inhibitors are very hard to deal with. They have resulted in patients developing myasthenia gravis, inflammation of the sac around the heart, of what we call myocarditis. Patients have developed rashes, horrible colitis. My one patient many years ago who went on a drug called Epidemiologist ended up going to the bathroom for diarrhea no less than 30 times in one day. So there are side effects to everything. I think we all agree to that. But the most important thing is understanding that we have to recognize that and look at the risk-benefit ratio. So really, I could speak for hours on this, and that's beyond the purview of today's talk. If there's one thing that I would like to leave you with, because I do want to keep on time, and that is there's absolutely no one who should be overwhelmed or concerned with having treatments for their cancer. If you're going to have prostate cancer, this is the time to have it because people are definitely living longer. Thank you.
Thank you. Good morning. Good afternoon. It's my pleasure to be here today. I'm going to continue our discussion about treatment options for men with metastatic castration-resistant prostate cancer. And as Dr. Slovin so nicely covered, the androgen receptor and androgen receptor axis therapies, my focus is going to be on standard of care treatment options, including chemotherapy, as well as a radiopharmaceutical called radium-223 or Xofigo. And then what I'd like to do is talk, give an overview of clinical trials and what it means to be a part of those, as well as highlight a few therapies that are in the investigational setting, but hopefully will be approved in the near future. So for chemotherapy in prostate cancer, we typically are using a class of chemotherapy called taxanes. The first taxane chemotherapy to be approved is a drug called docetaxel chemotherapy. It was a drug that was actually originally derived from the bark of the Pacific yew tree, believe it or not, and it's something called an antimicrotubule. And microtubules are sort of like the scaffolding system for a cell, and by disrupting that scaffolding, you can actually impair cell division and cause cell death. So many years ago, there was a clinical trial that evaluated docetaxel chemotherapy when it was given intravenously. And this clinical trial had sort of 3 different groups of men in the trial that were receiving different therapies, all with castration-resistant disease. Docetaxel was either given as a large dose once every 3 weeks, or a smaller dose given weekly, or the comparison arm, or the comparison group, was receiving a chemotherapy drug called mitoxantrone, which is another drug that's approved in prostate cancer and was the only other therapy really available for men at that time. I will mention that mitoxantrone is a drug that has never been shown to make men live longer or prolong survival. It's a drug that was approved on the basis of improving pain related to bone metastases. So the conclusion of that large clinical trial back in 2003, 2004, was that chemotherapy with docetaxel given once every 3 weeks as a larger dose was more effective than the other 2 options. And for that reason, it's remained in our armamentarium for many years. With docetaxel chemotherapy, there are some expected side effects, and men experience these side effects really to varying degrees. Fatigue or tiredness is common. Myelosuppression, or an impairment of the bone marrow's ability to produce red blood cells and white blood cells and platelet counts the way it normally would, is also an expected part of chemotherapy, but a temporary one. So men are at risk for infections when they're receiving chemotherapy. With docetaxel chemotherapy, you can get neuropathy or numbness and tingling in the fingertips and toes. Chemotherapy can also cause hair loss and changes in the nails, and that's obviously very important because someone's physical appearance is affected by chemotherapy. And I know a situation that can be quite disruptive to somebody's normal life. So fast forward from docetaxel to around 2010, and there was another chemotherapy drug that was approved, and that's called cabazitaxel, or Jevtana is the other name for it. In this clinical trial that sort of put cabazitaxel on the map, it was given intravenously once every 3 weeks, and its comparison arm was our old friend mitoxantrone again. All of the men on that clinical trial had already received docetaxel. The conclusion of that study was that cabazitaxel could extend life and prolong life and quality of life relative to mitoxantrone. Side effects of cabazitaxel chemotherapy are very similar to docetaxel chemotherapy. So fatigue or tiredness, decreases in the white blood cell count with higher risk for infections, neuropathies can all happen with cabazitaxel chemotherapy. So you might ask, well, which chemotherapy drug would you use first if somebody's at a position in their treatment where they would need chemotherapy? And I would say in general, we tend to use docetaxel chemotherapy before cabazitaxel, in large part because we have big clinical trials that have shown us that cabazitaxel can be effective even for men who've already had docetaxel for castration-resistant disease. But all that said, there have been studies that have compared these 2 drugs head-to-head, and they look fairly equivalent with similar toxicity profiles. So beyond chemotherapy, or I should say even before chemotherapy, another treatment option that we should talk about is a drug called radium-223, or Xofigo. This is what we call an alpha-emitting radiopharmaceutical. You can think of it as a liquid radiation drug. It's given intravenously once a month for a total of 6 treatments altogether. The way radium works is it's attracted to calcium uptake. So it tends to affect the area in and around surrounding bone metastases. And in clinical trials, large studies, radium-223 was also associated with a prolongation of life, and therefore is FDA approved in this setting. And I can say it's effective for men both before chemotherapy and after chemotherapy, so it can sort of be used in either scenario. The side effects associated with radium-223 are mostly gastrointestinal, meaning some nausea, some diarrhea. It can lower the hemoglobin levels. But for the most part, we think of this as a well-tolerated drug with relatively few side effects. And I would say on the whole, certainly fewer side effects than chemotherapy has. One important thing to know about radium-223 is because, again, it's targeting bone metastases in the areas around the bone, it's really only appropriate for men that have bone metastases and not cancer elsewhere. So if men have prostate cancer affecting the liver or the lungs or large lymph nodes, it's not going to be a good therapy for them because it's not going to attack those other areas of metastatic disease. The other thing that's important to know about radium-223 that can be somewhat challenging is it tends not to lower PSA. And as we all know, this is a disease where everybody's very focused on PSA, and is my PSA rising or is it declining? For radium-223, only about 15 to 20% of the time will you see a PSA reduction, but that doesn't mean the drug isn't working. It's been approved on the basis of men living longer who receive the radium relative to those who do not. But it does propose some challenges when we monitor for the effects of treatment. Radium-223 can certainly help symptoms like bone pain. So for a patient who's receiving radium-223, who's coming onto that treatment having some symptoms of pain related to bone metastases and that pain improves, then you know the drug is working and it's reassuring to be continuing to move forward. So that's chemotherapy and Xofigo.